Our usual, our usual suspects. Okay. All right. Well, I will start whenever you want me to start. And
Okay.
good evening, everyone. I hope that
All righty.
it sounded like me, and I wasn't even talking.
No, it wasn't. It was oh shoot, what am I looking for? I pressed the wrong button. Okay, now I see the button. Record. Okay. Let's see how many we have. Oh, we have 8. Somebody else stuck in while I wasn't looking. Let's give them another minute.
Okay.
What is it now? 7:04. So we'll give them 7:06. 2
All right.
minutes.
Hey, Daryl.
Hey there.
You don't call a sister back. I called you yesterday.
Mm.
We're about to meet you, Andrea.
Yeah.
Hello.
Yeah.
Oh,
Yeah.
hey, David. How are you doing?
Please,
Oh, that's right.
please mute her as fast as possible.
Uh-oh.
She's trying to bust me out, so please mute
Oh,
her.
shoot. Oh, Dr. Harrington, I'm sorry.
I don't care about the doctor. It's the callback thing that's bothering me right now. Yeah.
No, I'm putting on my
Andre, you've already blasted him over the airways with everything.
Yeah. Yeah. It's too late. It's over.
It's a sibling thing.
I had a moment. Forgive me.
It's 7:06, so we will start.
Okay.
Okay, good afternoon, almost evening, everyone. It's so good to see you all. I hope you've had a good weekend. It was a long weekend, and we're now back almost 2 weeks later to update, talk, discuss, debate, share some thoughts about coronavirus. Before we get started, I'd like to just offer a word of prayer, and then we'll jump right into it. Most gracious Heavenly Father, we thank you again for another day, for the countless blessings, recognized and unrecognized, that are part of each day in our lives. Thank you for each of the voices, minds, and hearts that are represented on this call. And thank you for their continued commitment and interest in their personal health and health of others around them. We ask that you be with me and be with those who are participating as we learn together and share together on and about this important and to some very devastating disease of coronavirus. Be with us and keep our minds and hearts open. Use me, dear Jesus, in Jesus' name I pray, amen. Okay.
Amen.
So this is it's kind of hard to believe this is number 10. We've been talking about coronavirus for a long time. You would think we have run out of things to say, but there's a lot to continue to say and talk about. And as usual, we'll talk about some of the trends, particularly in LA County, and then address some questions as they relate to some of the things that were submitted, as well as some things that have been observed. And as a reminder to everybody, this is my reminder to tell you guys that sort of it's important to remember not to let the smooth taste fool you. And so that means that this is a disease that spends a fair amount of its time with minimal or no symptoms. in the community, be it in a household, be it in a gathering, or sometimes just in small, intimate settings, and can be transmitted because it's contagious without people having major symptoms or minimum symptoms quite readily. And again, even though it's very similar, just a little bit more contagious than the flu, it's the fact that people can have these symptoms for so long that makes it much more challenging. So again, just a word to the wise, and I'll end with this, just as I'm beginning, to really stay vigilant, stay safe, and to remember that we're not just talking about droplet precautions and inhaling this virus, but we really are also talking about contaminating surfaces in our hands and contaminating our mucosal surfaces with this virus. And so it's really important to, again, remain vigilant. I know many of you have looked and kept up with the news with regard to a variety of reports, particularly reports that in California and even particularly in Los Angeles County, we have continued to see increased numbers of cases. To your left is what you see represented in our first broadcast on April 6th, where we only had 16,000 cases. And you can now see that's in LA County, and now you can see we have almost 300,000 cases. If you look at the daily case rate back in April 6th, it was 1,100 or so, almost 1,200. And you can see now we're in the 8,000 range per day. Now, this is partly due to simply having more testing available. So we are testing a lot more people. And that's one of the reasons for a large difference in numbers in April versus July. But the other reason that's actually very different is that there's more community spread. So having more testing only partially explains this sort of really drastic change in numbers. And the support of this is actually based on something that we can't falsely inflate, at least not in such large amounts, and that's the number of deaths. And so if you look at the number of deaths in one day, the number of deaths in one day in April 6th, it was about 30 deaths per day in early April. And now you can see that we have somewhere between 80 and 90 deaths per day. Okay, so that tells you it's not just related to testing, but it's actually related to people who have the disease. So there are more people who are sick with this disease, almost 2 or 3 times more people who are sick with this disease now and dying from it now than were 2.5 to 3 months ago. Okay, that's objective information. Death is an objective endpoint. It can't be falsely elevated like testing. Now, having said that, I want to jump right into this conversation about reopening LA County. As many of you all remember, the idea of opening and reopening counties was to follow the CDC guidelines, and it was based on 5 metrics: deaths, hospitalization and hospital capacity, the supply of personal protective equipment, the availability of testing, and contact tracing based on the public health department. And so if you look at the deaths were specifically designed to talk about the number of deaths averaged over the last 7 days. So this can be actually falsely reassuring, because if you look at this data, it's a 25% decrease. And as I'm going to show you in a second, the deaths per day dramatically fluctuate on any given day because deaths lag, and the reporting of deaths actually lag and can sometimes be grouped or aggregated. So this as an outcome is not a good outcome or reliable outcome because of the way it's defined and the way it's reported. PPE, we have lots of PPE that's now available. We have more and more testing available, although we're not testing asymptomatic people. And I would argue that our contact tracing, although it meets a minimum standard, is far from adequate if you talk to our people in public health. So let's look at deaths, for example. And when you look at deaths on this graph, what you see are the daily deaths in the solid blue line. And they proportionally, if you go back to March, in early March and April, and let me just use my pointer here. If you go back to here, we sort of had a rate in the 1 to 2% range. And if you look at the daily cases, which are in light blue, they were actually daily cases of deaths by episode. We're way down here. And this is in, all of Los Angeles County, okay, daily cases. And then you can see now the daily cases on averages are way up here. Some may say, well, that's just testing, right? That's just testing. But then if you look at this fine line, I'm going to actually try to see if I can blow this up. Technology, right? So now on this really dark blue bar down here at the bottom, which almost looks like it's a solid line, you can see that the number of deaths back in March and April were basically at the bottom of that line. And now we have increased deaths, which increased by fourfold, okay, over the months of late April, May, and June. And while those are going down in July, again, we had our total number of cases initially going down here. And so now that we're sort of going back up, as I'll show you, we have to wait a little while longer because death lags to actually see if we have a reduction or continued reduction in death rates. So again, death by itself is not, it's too early to use death as a predictor based on just the fact that we have increased number of cases and, as I'll show you in a second, increased number of hospitalizations. So in this, as the second metric for reopening, was this whole discussion that we need or we must have a daily number of hospitalized COVID-19 patients in the past 3 days average that actually gets reduced, that doesn't increase. And what you can see here is that we've had not a stable number of hospitalized patients, but we've had an increase of 35%. And this slide is actually not updated over the last 4 days. So that number is actually even higher. Now, again, we'll have to look at that number and look at a lag of 2 to 3 weeks before we can say whether or not the death rate has changed or not. And this is important because there's been increasing observation that the rate of death from the disease, the case fatality rate from this disease, is changing or going down. And that has something to do with the people who are getting this, which we can talk a little bit about. Well, I might as well bring that up now. As you all know, when this first hit, there were lots of elderly nursing home or skilled nursing facility patients who were hospitalized, and they had a higher case fatality rate. We know that we had higher rates of people who had chronic comorbidities, et cetera, who were infected and hospitalized. Now, if you look at the people who are hospitalized, these are people with fewer comorbidities. And in fact, many people who actually have commercial insurance and are not even coming to our county hospitals, but are at the UCLAs, the Cedars-Sinai's, and the community hospitals of the world. And so they're younger patients with less comorbidities, and they're being hospitalized. And because they have less comorbidities and they're younger, their case fatality rate is lower. It doesn't mean that they're zero, it doesn't mean that they don't have a risk. They, in fact, do still have significant risk of dying. But even if it's 1 or 2%, that 1 or 2%, that 1 in 100 or that 1 in 50, when you look at the numbers of people who are getting infected, means that there's still a lot of people out there who can die. So this is a graph of LA County, Los Angeles County, including 70 plus hospitals across the county, to look at the numbers of people who are hospitalized, and then to also look at the proportion of people who are in the ICU. And what you can see on the graph to your left is just the number of confirmed cases, suspected cases in light blue, and confirmed cases in dark blue. And so again, looking at our peak in April, end of April, we were here, okay? We showed a slight decrease, but not really a resolution like in New York. We just showed sort of a slight decrease and stayed at this sort of happy norm for about a month or so. And then they reopened things. And you can see we're now just slightly higher than we were at our peak in the end of April. When we look at the number of people who are in the hospital and where they are in the hospital, overall, this line, this mean regression line that I'm drawing, shows you that there's a decreased proportion of people. We had somewhere around 42% of people who were in the ICU if you were in the hospital, and now it's just under 30%. So that means one of two things. People aren't as sick, and that may reflect a different population of people getting sick, but also may reflect that we have learned more about this disease and we're treating this disease differently. And I'll talk a little bit more about this because this has to do with one of the questions that was asked about happy hypoxemia. So we've learned more about the disease, we're treating it differently, so survival may be better, but also people with less complications, less risk for death are being infected. So what stage are we really in? We were really looking at reopening up and moving from stage 2 to stage 3, but a halt was put on that a little bit. And so we are back at what I would describe as, and I think what people would accurately describe as stage 2. We are not pushed to move into stage 3, although there was a slight tilt towards that. This is kind of really important because it's going to kind of talk a little bit about what sort of businesses and what sort of risks should we take, particularly given that all 5 conditions have not been met. And in fact, we know for sure one condition hasn't been met by a long shot, which is one of the most important ones, the number of people who are in the hospital. And the second one, which is inaccurate, which is the number of deaths, cannot be used accurately to predict whether we should reopen or not, just because there's such a lag in the reported deaths. So is it appropriate to push the reopening? Well, I'll remain that for our conversation, but I would suggest that with increasing hospitalizations and not knowing where that's going to end, we should be very, very cautious about reopening or expanding reopening. So on July 4th, the health officer of the Department of Public Health in the County of Los Angeles revised the previously published order as it relates to reopening the community and the County of Los Angeles. And it's available at the CDPH, that's the County of Los Angeles Department of Public Health website, if you all want to read the 17-page document. I just wanted this to be here so that you guys know that it's been revised. And I wanted to point out a couple of things. In the document, the health officer orders the closure of very specific venues. And what you need to recognize is that some of this may seem a little arbitrary. And then you'd have to ask yourself, what sort of behaviors are they really trying to diminish? So lounges and nightclubs and bars and tasting rooms, this actually is trying to diminish the idea that people are eating, right, and are actually in very close contact, which you cannot prevent in settings like bars or pubs and lounges and nightclubs. So that makes sense. This is actually saying that proximity and not being able to control even the mask being off, even if you had a must-wear mask order, is important in these 3 areas. So that makes pretty good sense. Public entertainment venues, again, even if you did spacing, etc., many of these live performances and theaters, the concession stands would be open, people would be eating. It would be very hard based on the activities or what have you for people not to keep their mask on, as well as to congregate, because that's what people do, particularly in entertainment venues. Family entertainment centers is the same way, as well as restaurants that are indoor. This idea of outdoor restaurants is still being allowed for at least the coming days. But again, as you all have driven past open restaurants, I'm sure you've seen people sort of back to back or table to table in proximity with each other without mask on eating. And again, many of which may not even be coming from the same household. So again, this is something that I think is interesting. You have a restaurant that's open because it has exposure to the outdoor, even if a lot of the indoor area has really close proximity and people aren't wearing masks, that restaurant is allowed to be open. Card rooms, etc., make sense, just like the first few on this. Indoor and outdoor playgrounds for children, okay, except those located within a school or child care center. And again, a lot of this because so many of the kids are asymptomatic. And again, adherence to precautions, hand hygiene, and wearing a mask is very difficult, that they should be closed. Indoor portions of exhibit museums, and again, this is sort of the entertainment piece as well. And then again, hot tubs and steam rooms and saunas have nothing to do with the water per se. It's really more of what happens, people breathing heavy in an enclosed area, etc. That actually encourages transmission of infection. And then it says all events and gatherings unless specified allowed by this order. So you have to read more in the order, and it goes through a variety of venues and gatherings which are allowed. And we'll come back to that when we talk about churches. So are we slowing the spread, and how capable are we of slowing the spread? And we really want to know the answer to this because of the resources in the healthcare system. We are about 80% to 85% capacity across LA County. So today, on one of my huddles or meetings within the County of Los Angeles, it was 82% capacity. We're at 82% capacity with regard to sufficient beds to care for people who have COVID infection and require hospitalization and monitoring. So we have very little capacity left if we continue to spread at an increased rate. All right. And then there's the question about how effective are we in slowing the spread? And we're effective at slowing the spread. We can measure that just by hospitalization and death rates. But we know we're effective at slowing the spread if we have policies in place that actually change or mitigate behaviors that we know spread the disease. And so, again, we've talked about this. What are the things that actually spread the disease? And again, physical proximity spreads this disease. Inhalation spreads this disease in a inhalation droplet precaution sort of disease. And again, everything that's attached to that. So that means controlling your environment and controlling the proximity of others around you. And until we can actually do that well, in a way that is informed, it's going to be very difficult to control the spread of this disease. Okay, so having said that, let me pause there before I get into some of the questions that were asked and ask if folk have questions right now. And you can put that in the chat or you can unmute yourself. Okay, so maybe what I'll do while you guys are getting warmed up is let me answer some of the questions that were typed in earlier. What is happy hypoxia? It's also called silent hypoxemia. And without giving you a complicated medical graph, I thought I would just explain this in a way that I think is comfortable and makes sense. Typically, when someone is short of breath, we call that dyspnea. It means that we're not getting enough oxygen. And when you don't get enough oxygen, you feel anxious. You feel like you're suffocating, like you're not getting enough air. And it's either difficult for you to breathe, or you're just have the sensation that you want to breathe more. Happy hypoxia is this notion that even though you're not getting enough oxygen, you're happy about it. You're not complaining about it. You're actually sitting there comfortable. And this is something that's actually well known. We see this, for example, with carbon monoxide poisoning. Okay, So someone with carbon monoxide poisoning, this is why we have carbon monoxide, um, devices and alarms in our house, because carbon monoxide silently will kill us by causing severe hypoxia and hypoxemia without us knowing it. Now, why is that? Why does it occur in this way where our oxygen levels are very low, but we don't sense it? Well, in carbon monoxide poisoning, for example, it actually affects certain parts of our brain and chemicals in our brain that are typically activated that says, hey, you're short of breath. And one of those important baroreceptors or chemical receptors actually listens to carbon dioxide and acid. And when the acid and carbon dioxide is detected at high levels, our brain says, uh-oh, I need more oxygen. And we breathe more. We feel anxious and we try to breathe more rapidly. Well, in carbon monoxide poisoning, those receptors are tricked or fooled into thinking that everything is okay. So you don't breathe more rapidly. You don't say, hey, you know what? I'm short of breath. And you stay in an environment where, in fact, you're getting less and less oxygen to your tissues, to your brain, to your heart. And people actually end up having heart attacks or strokes and ultimately die with carbon dioxide poisoning. And so similarly, even though it's a slightly different mechanism, people who have COVID-19, it's been shown in some percent of patients that they can have severe amounts of hypoxemia, low levels of oxygen in their blood. And despite having low levels of oxygen in their blood, they're not prompted through their receptors, through a variety of complicated physiologic mechanisms, to breathe faster, to feel anxious that I'm not getting enough oxygen. And so even though we're measuring with devices while they're in the hospital that their blood count is very, very low, that the level of oxygen is very low, the person's on the phone, the person's sitting there comfortable. And we're coming to them, rushing with them to a tube to intubate them, to put them on a breathing machine when they actually feel comfortable. So that's what happy hypoxia is. And the mechanism of that includes a variety of things, which are sort of technical language. It includes something we call right to left shunts. It includes changes in the physiology of the lung units in the lung, et cetera, a variety of things that they think are related to the virus itself. But nonetheless, it's one of those things that gets us very excited when we see a number, even though the patient, when we ask them, are they okay? They say they're okay. And so this is, again, and kind of important as well, because if you're sick at home and you're coughing or short of breath a little bit, it could be, in fact, that you're even more severely short of breath. More hypoxic than you know because of this happy hypoxia. So if you are feeling sick, not feeling well, if you're feeling fatigued, even if you're not anxious and screaming for oxygen, it's probably wise to get checked out. Okay. Next question was, what are the projections of, I said Coxit, but it's COVID-19 over the next several months? And there have been a number of projections or models that have been published. One done by Dr. Roger Lewis, who works with me and is one of our emergency medicine physicians, who's also a PhD in statistics. And he has been hired by the LA County to make projections based on a variety of inputs into models. And you should know that in our early evidence, we had somewhere between 140 and 101 and 450 people who were infected in LA County. So again, somewhere between 1 in 400 and 1 in 450 people were infected. We now are closer to about 1 in 100. And I will tell you that that means that there are 4 times as many people around you at any given time who are infected. And that is a conservative estimate. This also means that when we think about how many people will require hospitalization, it's assumed that somewhere between 1 in 40 people who are infected will require a hospitalization. And it also assumes that we maintain a steady rate of transmission. And that's a very big assumption, if you will, with no change in infectivity. And when you look at that, just looking at the projections of how many people, how many new cases we'll have, understanding that 1 in 40 will require hospitalization, we have a large increase, potentially a doubling to quadrupling of daily number of patients who are infected. And if you just double or quadruple the number of people who are infected, that means that you will double or quadruple the number of people who are in the hospital. Remember, I told you we are already at 80% capacity. So it's just because of this type of projection, both in the short term, meaning over the month of July, versus if you look at this data and look at the timeline, we're looking at August, September, October, over the summer, right? We're anticipating that just over the summer, we could have a double or tripling of the number of people who are actually infected, and therefore the number of people who require hospitalization. And that could mean that we are like some parts of Arizona or some parts of Texas, where they're having to make decisions to ration care because we don't have enough beds in the hospital and we don't have enough ventilators or enough ICU. So remember, this was the place that New York was in April, and we're seeing this play out already in other states like Arizona, like Texas. And we're anticipating that that could happen here in California, but particularly in Los Angeles, particularly because there's so much rush to reopening. And with the message of reopening, it also sends a strong message of, I'm okay. This is not a big deal. I can go back and have fun or do whatever I'd like to do. And we have seen this already in just the 1 week after expanding a little bit, nudging a little bit into sort of stage 3 with regard to our bars and restaurants. Where did the new symptoms come from? The new symptoms came from observations from the medical community as we learned more and more about the disease. So as we have a registry of patients, and now we have thousands and thousands of patients in the registry here in the United States, we're actually able to learn from those registries and to actually better understand what subtle signs and symptoms may really be part of the syndrome versus just part of the population as a whole. So this is what happens when we chronicle or detail experiences of patients with any disease, but in this case, COVID-19. So I'm going to pause there, and we can take any questions you want. We can focus the conversation on the church reopening, whatever you like, but I'm here at your disposal. The first question I see in the chat is, does the increase in weather temperature have any impact on the spread of the virus? Well, this is a very good question, Val. On the one hand, it's true that most respiratory illnesses of droplet precaution or otherwise, that warm weather, not extreme warm weather, but warm temperate weather like we have in Southern California, could be associated with a decrease in spread of the virus. Why? Because people are up and out and they're outside. However, remember that historically is true of viruses which have had a short incubation period, and we know who's sick, right? So when you have an incubation period of 1, 2, 3, or 4 days, and the asymptomatic phase is very short, then we know who's sick, and people can self-isolate very quickly. And so people in a warm weather or temperate weather, it's very pleasant, people want to go outside, as an example, self-isolate, self-quarantine in situations like that. However, when you have a disease where there's a large proportion of people who are asymptomatic or have minimum symptoms whatsoever, then people are going outside and they're getting together. And in general, outside is safe until you're outside for prolonged periods of time around people in proximity. Then outside is no longer a bastion of safety. So in an outdoor restaurant, for example, where someone's sitting across from a friend, they don't live together, but it's some friend who's actually asymptomatic and infected and shedding the virus, and they're at dinner, sitting across from each other for 3 hours, that's no longer, even if it's outside, a low risk behavior. Okay. Versus I'm outside jogging and walking past somebody, or I see someone very casually because they drive up my driveway and I go outside to greet them. Those are casual, very limited interaction. So it's a very good point. It's really all about the density, the infectivity, and the elongation or prolongation of the interaction of the individuals. Now, as you get warmer and warmer, so it now gets like Phoenix hot, Las Vegas hot, Texas hot. Now it's so warm that people are spending more time inside. And then warm weathers are not associated with the decrease in spread of the virus.
So, Doc, it seems like we exhibited or engaged in low risk behavior far too quickly, which may have attributed to the spike. Can you confirm that? And then can we pull back just as quickly as we spiked up?
So it's a good question. The first one is makes the assumption that the behavior that we participated in was indeed low risk. And so I'm gonna push back on that just a little and say that the intention of the behaviors was low risk, but the application and practice of those behaviors were far from low risk.
Good
So,
distinction.
yeah, so the idea that someone reopened up a restaurant or a pub or an activity and said, hey, you guys have at it. No mask, no hand hygiene, and you can just go in there, no physical distancing, right? That's very high risk behavior, right? And so remember, screening people before you even go into a restaurant or a dance hall because you're going to take temperatures or have them say, oh, I feel good, only takes care of 50% of the people who might be infected. The other 50% of the people are going to have no symptoms or no fever at all. So I think that it was the behavior, the implementation, if you will, of those sort of establishments and behaviors and activities, which was the high risk, which made sort of lower risk activities actually high risk. And then the second question that you asked, Derek, which I think is a really good one, which is sort of, once you let the genie out, how quickly can you put the genie back in the bottle? And unfortunately, it's much harder. I like to remind everybody that, again, this 6 months later, we had our first case in January, okay? Our first known case was in January. 6 months later, how many cases do we have in the United States, right? And so once the genie is out of the bag in the community, if you're unable to identify infections and isolate or quarantine those infections, it's hard to put the genie back in the bottle. And because most people have minimum or no symptoms, right? How do you put that genie back in the bottle? How do I identify you, right? We're not testing routinely asymptomatic people. And remember, testing asymptomatic people early may give you a false negative. So because of the natural history of this disease, putting the genie back in the bottle and seeing a return to prior levels of infection or prior spread will be delayed quite a bit. So we will have, I guarantee you, an increase and sort of pseudo surge again for the coming weeks. I'm seeing this in my data at my own hospital and across our system automatically. So I guarantee you we will have an increase. The question will be, how high will it go? And will we be able to flatten that to some degree by changing our behaviors? And I'm not optimistic about that too much because our mayors and our governors are motivated by a variety of conflicts that make it difficult to take more draconian measures. And I understand it. We have to stimulate the economy, et cetera, et cetera. I mean, a variety of things. But there are things that they could do to really change things to some degree. But I want you all to remember, if you look at the global data, the global statistics around the world, every place that's sort of reopening, even New Zealand, okay, which was like our poster child for doing the right thing. As you reopen, if you have a single case that's undetected, that's mingling around in aggregate, and you've removed some of the mitigating strategies because you're reopening, the disease will come back. It's a guarantee.
Can we push that a little bit? So if that one individual, just the one, wears a mask, everybody knows who that person is and keeps a reasonable distance from that person and does not engage that individual for longer than say half an hour, then what would you estimate? We're just estimating here to push that case. Could that slow and reduce and maybe stave off potential spread?
Absolutely. And that theoretical scenario requires us to know who's positive and asymptomatic.
Right. So
Right.
if we just assume everybody is and behave that way, can we flatten it?
Yes, but the behavior requires lots of accountability. And that's where the problem is that individual and group accountability is near impossible, right? So, so you're raising the question that's related to even the church reopening, right? And so I do think that you have to put practical matters into that. And so let's just go down your line of questioning a little further. Assume everyone is infected. How can you protect the spread? Okay. Assume everyone is infected.
Right.
And I'm going to put one person, I'm going to introduce one person into the environment who isn't infected.
Okay.
How can I prevent that one person in the environment from getting infected? Is that possible? Right? What measures can we do? That's the way we should be thinking about
Right.
opening or doing things that are non-essential, if we
Okay.
want to kind of guarantee that. And
Right.
the way you do that is not minimizing the physical distancing, but optimizing it beyond the 6 feet, so you sort of take extra precaution, number
Okay.
one. Number two, you mandate mask wearing.
Right.
And you do not create or allow situations where people will take their mask off. So people won't be singing, people won't be eating, people won't be forcibly getting tired and exercising or pushing through the partial pressure of inhalation attached to, if you will, what the mask can protect. So you're doing hand hygiene, and you're doing hand hygiene early and often, and you're mitigating ingress and egress into an area to minimize even casual contact and exposure, right?
Right.
You're making sure the individual who you're trying to protect doesn't have any risk or minimizes their risk of having complications. So if you were wrong or you were unable to protect them and they got infected, that this is an individual who has a high chance of a bad outcome. So
Right.
you're removing from the environment or prohibiting from the environment people who are at high risk for having not just death. And let me just say this, people are only thinking about death. This is proving to be not just an acute illness that you get over, you either die or you survive, but it's proving to be a disease which has chronic complications. And some of those chronic complications include chronic lung disease. And so again, depending on your reserve and where you are, this could play a really important role in your life in the future. And so I feel good right now, but 10 years from now, because I have this chronic lung injury from getting infected, I am now oxygen dependent, for example. Okay, so I think we have to think about the the sort of continuum of complications and not just live or die.
Right.
Okay. So yeah, it's a really important question, and it's a tall order to ensure that it occurs. And that's why I think people can be more deliberate about thinking about pros and cons of doing something. So I think any business, at a minimum, should have a mask, hand hygiene policy. You can't even go into pick up your to-go order without having a mask on or doing hand hygiene. What I'm just saying that there are some simple things that should just be automatic.
Right.
Are people requiring that? I don't know where you guys have been, etc., but people aren't requiring that. You see people going into a store, one of these quote unquote essential businesses without mask on, because people don't want to, defer a profit for people who don't believe that, they should wear a mask. And there's no enforcement of that in our public health agency and our law enforcement, etc.
Right.
Question.
Now, did I stun you all so that this is unusual?
I have a
usually there are tons of questions, but people are just stunned. Okay.
Yes, Dr. Harrington, yes, I have a question. Am I mute?
No, I can hear you.
Okay. How long can this virus exist out there and then die out? Because if we're doing all this mitigation of washing our hands and wearing masks and doing everything, then it means we're preventing the virus from coming into our body. That's good. But how long can it be out there and then die out because it has no host? And are we going to be like this for a number of years to come?
Yeah, this is that's a really important question. I was hoping no one would ask that question. But it's an important question, and it's the right question to ask, to be honest. And so this gets us into a conversation about practicality over convenience, right? So you're absolutely right. Like what we're going through, what we're living through right now, for many of us is beyond inconvenient. And some of us, it's a mere inconvenience, and others, it's beyond inconvenient with regard to the economy and unemployment. A variety of things have been the consequence of sort of shutting down or near shutting down. So I think that's on the one hand. The other hand, which is the practical part that you're talking about, is why don't we just kind of get it over with? I'm not saying that you're saying this, but that's the argument is people who are going to die from this are going to die from this. People who are going to get sick and have complications are going to get sick and have complications. Why don't we just let it rip through the community and our population? And if we do so, we can develop herd immunity, if that's possible, with 70% of the population or more having it. The virus will go away and die off. So it'll be what it'll be, and we'll be past this. Well, that's the observation when you look at some of the great plagues and the great, pandemics that we've had in the past, where turn of the century, millions of people die off and everyone's dead, and because the people are dead and there's no more survivable host, the virus is gone. That idea works again well when you have extremely virulent or extremely high case fatality rate, number one. It works well when the infectivity is high and the incubation periods are short. When you have long incubation periods and variable penetrance with a sort of modest to low case fatality rate, it means that by definition, it doesn't die out as quick. It actually has to work its way through a lot more people, number one, and you can have a large number of people sick simultaneously for a prolonged period of time. So again, just think about this. We have 10 million people, 11 million almost, in LA County. Just look at that in LA County. I've shown you guys the number of beds we have, like, over and over again in the variety of presentations, right? The number of ICU beds, the number of ventilators, etc. We don't have that many ventilators here, okay? We just don't, okay? A few thousand ventilators, and then that's it. So imagine, just do the math, 10 million people, and at one time, 1%. So again, 1% is 100,000, okay? And if I have 100,000 people at one time actively infected, and 1 in 40 of those people are hospitalized, based on our current sort of projections, okay? We are literally at war, putting X's on people's foreheads, because we do not have resources to care for even a fraction of that number of people. Do you understand that? Right? That's a lot of people. That's 20,000. Okay? Or not 20,000. That's 2,500. Sorry, that's 2,500 people each day, right? Who require hospitalization and ventilation. And that number continues to grow because the length of illness and hospitalization is long. It's not like 1 or 2 days. You die, you get sick, you die, or you get better. 2 or 3 days, it's over with. People are in the hospital for a week, 2 weeks, 3 weeks. So that 2,500 patients in one day, by the 4th day, it's 10,000 people in the hospital. By a week, you're going to discharge some, but you're going to be closer to 14,000 people in the hospital, in an ICU, sick, etc. Right? So you can see how quickly, because of the nature of this disease, it adds up. And so the idea of letting it run rapid, if you will, as opposed to slowing it down, the trade-off for that is, it is important for us to think about what the value of an individual life is versus the suffering or inconvenience of this prolonged, sort of slow percolation in our society, in our population. If you have a slow burn, then you manage all the people and you treat all the people and you save more lives over a prolonged period of time. If you have a more acute burn, you overwhelm the system, more people die who may not have died if you had a slow burn. And then you assume that you save some time, you save some convenience, you get the economy back on its feet. And so again, it becomes a value, an ethical decision. What's important, right? What's important to you? And what I would say for everyone who's on the call, that for me, if it were my son or my daughter, my spouse, my sibling, then every life matters, right? It's easy to make the ethical decision the other way when it doesn't include you.
So we're not seeing any reprieve out of this just now.
Well, I don't think so. I think what you're seeing, based on the way the health order is written, to be honest with you, is a compromise. Like, no one is saying up front, hey, we must save every life. Because if that were the case, we would have much more strict stay-at-home orders. The fact that they've opened up businesses, that there's no draconian measures of law enforcement to begin ticketing people who are, walking around or going into establishments without masks, etc. The fact that establishments are open without any sort of you must have a mask or we don't serve you sort of thing. None of that's in place. And to me, what that tells me is that it's sort of a soft way of saying exactly what you're saying, Janice. We're not going to put the reins on this completely. We're going to sort of let this go at a moderate rate. And that's what's happening. It's not gangbusters, but it's a moderate rate so that we don't overwhelm our health system, but we still allow people to get sick and die. And whether or not our policymakers, our leadership are making that decision knowingly or not, I don't want to impugn any judgment on them. But it is a calculated decision and a calculated risk. And one could understand why this sort of rationale decision might be made.
Close or not?
Let me get to a question that's in
Sure.
here real quick. In a prior podcast, the question was asked, what would push us back to phase one? The response was that it was unlikely because of adequate bed and ICU capacity. At the time, that was true. Today, the number is significantly up for bed capacity. Has there been discussion of a percent that will determine the return to phase one? Not publicly, no. That's a really good question. In the beginning, we had more than adequate capacity in LA County. Now that we are seeing sort of an increased numbers again, and remember the increased numbers are for two reasons. One is COVID cases, and the other is non-COVID cases that require hospitalization and ICU care. So we still have people having strokes and heart attacks and pneumonia and other things that are not COVID that require hospitalization. So it's because we still are taking care of other people with other illnesses, along with the increase in COVID cases, that is actually getting us to our bed capacity, okay? And what it would take to make us go back to phase one, I'm very cynical about that happening because I think that we really are talking about the will of people and the will of the dollar, okay? The will of people, even though there are people who are saying profit over people is the mantra, what I'm trying to tell you, it's people who are pushing profit over people, okay? And that is not just politicians or governors or the elite 1% capitalistic class, but it also includes consumers and regular people like you and me who are tired of their rights and their activities being infringed upon, right? Their freedom is being curtailed, and there are people who have just had enough of that, okay? Go ahead, Brother Moody.
I was going to ask, how close are we to a vaccine? We've heard varying reports about being close and certain companies issuing things that they feel would be promising. Just how close are we to an actual vaccine?
Well, if we talk about vaccine research, the definition of close in a vacuum is, hey, we're close. But in the definition of us needing something, meaning like we want it tomorrow or next month, we're nowhere near close, right? So, you're not looking at a vaccine being truly ready and proven effective. And that's key, proven effective and safe. But effective, it being effective is what we really want for 6 months to a year, for sure, right? So what's happening now in some of the early vaccine trials, people are looking at, safety is one of the most important things. And then they're pushing through the safety phase one to phase two very, very quickly because they want to look at, risk of complications. And there are two endpoints, right? You want to be able to inoculate people and see whether the inoculation or the vaccination prevents you from getting the disease. That's number one. That's ideal. And number two, like for flu vaccine, whether or not getting the vaccine will decrease the severity of the illness. So either or would be considered a win. The first is unlikely to be proven durable and effective until you've really watched something over population for several months before you know it really is effective. Because immunity can wane, right? And so if I inoculate you, Derek, today, and then I expose you to a bunch of people, or even give you the virus and you don't show a reaction, the question is how long are you protected? So is it just for today, right? Or is it for 2 months or 3 months or 4 months where you need a booster, where you have to be revaccinated every 3 months, every 6 months, every year, right? And you don't know that effective, how effective that is in that regard for several months to a year, right? Likewise, the other outcome, which is whether or not it will change the severity, also takes some time. And you need it done over a large number of people that you can compare severity of complications in one population versus another population, which is real science and research. And in order to draw those clinical conclusions, it takes several months to do that. So we're not going to have any reliable vaccine in the next 6 months, no matter what reports you hear. It's unlikely that will be the case just because of the nature of vaccine research. But you'll hear people talking about, oh, we've shown that someone develops immunity, meaning they develop antibodies, right? So I go ahead and give you a vaccine. That vaccine instigates the immunological response, and then we go like, hey, that's a success. Well, yes, that's the first part. The second part is, now, does that protect you when you get the real thing? And if it protects you, how long it protects you? And those two parts take time.
All right.
I will remind you all that this is a virus that is kind of related to the cold virus. Okay. The coronavirus family also includes viruses that cause the common cold. This is also an RNA virus, like HIV, okay, like hepatitis C. And both of those two things should remind you that this is a virus that adapts and changes very quickly. Quickly in virus time means over months. So even if we do all this early research and we get a vaccine that we think is close based on the early biological features of early viruses, while we are trying to get that product, that vaccine ready, the virus itself may very well be changing, mutating in a way that may mean that vaccine is no longer effective. Okay, so this is really important. It means that a lot of the strategies, a lot of the things that we're hoping for are not black and white at all. It means that they're very nuanced and could be complicated in terms of trying to predict that this is just going to go away by itself, or we're going to come up with a cure, a vaccine that's going to work in a short order.
Dr. Harrington, one of my coworkers called me yesterday, said they saw a news report about COVID being airborne. And they said they're not letting nobody in their office. And I told them, said, I haven't let nobody in my office since we started this lockdown.
Yeah, so just remember, go ahead and finish the question, Dave, I'm sorry.
No, go ahead.
Yeah, just remember that the definition of airborne, true airborne disease versus droplet, there is a bit of an overlap. We talk about like Venn diagram. Yes, the virus is aerosolized or can be aerosolized. And when something is aerosolized, it is can stay in the air, if you will, for a period of time. Remember still that we are still talking about a virus or a particle that is acted upon by gravity, first and foremost. And that most of the viruses, almost all the virus that comes out as we breathe, comes out as moist air. We breathe in and out moist air. So gravity will act on this and it will drop to the ground. Okay. Now, having said that, true aerosolized things, like measles and things like that, the infectivity rate of that, we talked about the R coefficient, replication rate and infectivity rate is not 2.5 or 3, it's 40, 50. And we still do not see that. So just by looking at epidemiology, just by looking at how many people can get infected by one person getting infected, and we've done all that tracking epidemiologically, this is droplet, airborne/droplet, not pure airborne. If it was pure airborne, in 3 months or 4 months, we would have 5 million people infected in LA County. Okay, not 400,000, 300,000 or 400,000. I say that because it's probably underestimate, right? So I think that we have to separate what people see in a vacuum of a study, where someone actually takes a dye or a particle transmitter, and then they highlight that in some sort of detection method, including fluorescence, and they show you, oh, this stuff is there. Oh my goodness, that means that I'm going to get infected. Again, remember that it's 3 things, right? It's density and amount, right, which is really important. It's how long, so the length of the exposure. And then it's this other piece, which is exposure or risk of exposure, which is yourself, like your own immune system, etc. So all of that's actually important. Wearing a mask and safeguarding your digits, so doing the droplet precaution stuff with regard to touching things, has been shown to be virtually 100% effective. And if this were pure airborne, that would not be the case. Okay, has that changeability been observed, or is it that based upon the chemical components of the disease itself? I'm not sure. Val, can you restate that question?
Yeah, basically what I was asking, Doctor, is you mentioned how, like some of the other viruses that we are accustomed to, such as the flu and regular colds, how it adapts as time goes on. So I'm just asking, has that adaptation been observed, or is that just simply based upon the origin of the virus itself?
See. That's a good question. So there's been some observation of some mutations, early mutations, but not dramatic, and that's because it takes actually much more time, right? So if this virus, if we go back to Wuhan and say at best maybe it was September or October last year, that's a short period of time for viruses to adapt. Okay, so viruses adapt over years and years. The common cold virus that we have right now, at one point, killed people, okay, or killed animals. But it's adapted over a long period of time because, as Janice suggested, organisms in general like to survive. So it is adapted to be less virulent. The other reason for me bringing that up, this sort of, changeability, is this notion of sort of, I don't want to say common sense, but everyone on this call has had a cold more than once. Sometimes we've had multiple colds in the same month. Sometimes we have multiple colds from the same virus or virus family, in the same year. Everyone has experienced multiple colds from the same family of viruses. This is like that from our understanding of at least the virology, the biology. Now, what may make it different up front is that there's more severe response to it from our immune system standpoint of view, and it is killing some of its hosts. And so, again, at this point, we may react different to it. But the idea that we have a cold-like virus, that's an RNA virus, that belongs to a family of viruses that have a history of adapting, changing, mutating. That's the whole family has that history. It makes it less likely that we'll find a simple answer to this in the form of a vaccine, at least the first pass. And so I'm not trying to depress anybody at all. It's just really, again, my mantra is about, I want you all to take this stuff serious. I want you to maintain the conversation about how serious this is and to make decisions, risk benefit, when you take potential risk of compromising the integrity of yourself and the people around you, safety. As I joined the call, there are a couple of you who are having a conversation about, people that now firsthand or secondhand who have died from COVID-19, right? And I didn't hear all of the conversation, but what was happening is, as I was listening, eavesdropping on this conversation, is that it was becoming more and more real. Like the conversation is like, this isn't a joke, this isn't theoretical, this is really happening. This is really a disease. And when I hear people either ask me about it in that way or they talk about it and I hear them talking about it that way, I can only say that until you know somebody who's died from this, and especially until you know someone who is otherwise healthy who's died from this, there will be a continuation in your mind, a doubt in your mind to some degree about how bad this is. And that's why there's so many people walking around without masks, huddling together, aggregating together, doing all of these things in a cavalier fashion, without thinking, without regard to their real risk and safety or someone else's risk and safety.
Dr. Harrington, those plexiglass shields they use in grocery stores, are they effective?
No one's shown that they're effective. They, I think, provide some confidence, falsely so, maybe to some degree, positively so, for the customer. But really the idea is to protect the worker, right? So the idea of putting the plexiglass up isn't for the customer, it's for the worker. And so if the worker is actually wearing a mask, the plexiglass prevents some absorption, if you will, even though it's a fairly low risk, of virus that might be spread via coughing or through ineffective personal protective equipment that might get absorbed through the mucosa, particularly the mucosa of the eye, if you will, or the nose, or any part that's sort of uncovered. And so in that regard, it can be helpful. Just like in the medical field, we use a mask and we use a face shield, just like a welder, we use this face shield. And the idea, again, is that that's supposed to protect against direct insult absorption that might actually come to our face or even on the mask itself, because people have a tendency to touch the mask off and on, right? So it's marginally or incrementally helpful and keep employees safe who have to come back day in, day out. Any extra is a handful. Okay, so I have on the slide, let's talk about it. I only have about if you, I will respond to questions that you have. I will say that, as I've said on a couple of calls, I understand the impetus and the number of arguments to reopen the church, both on the people person side as well as organization, and it makes perfect sense. I get that. And what I would say is that even though the California Department of Public Health has come up with guidance about how we would do it if we want to do that, because it's one of the permissive places, and it's 25% of capacity, and it's all this sort of stuff. What I would say is that none of the things that they've put in writing have been proven, first off, to be successful, number one. And I'll give you a great example. For example, in one of our Nordic countries in Europe, where they have very low rates, they reopen schools and they put out guidance about reopening schools. And it included people wearing a mask mandatorily in the classroom, and a variety of other things, hand hygiene, et cetera, et cetera, et cetera, right? And they had people in the room, the small classroom. They had the teacher and another monitor person, all this stuff that you imagine, should work. And they were monitoring people with temperatures and symptom checks before they even came to the school. They had to close the school down because there was an outbreak at the school. And the reason why there's an outbreak at the school is that because no matter how hard you try, human behavior prevails. And so, again, people would have to ask the question, like, is it worth it? So they closed the school down. They went to remote learning, online learning, and that was it for that school district. And so I think in church, it's the same thing. We have to think about why we're doing it. I think there's some good reasons why people want to do it. And then when we think about how we do it, if we talk about science and what we know versus people's best guess and what risk we want to take, that's where we have to be honest with ourselves. What the Department of Public Health has given you as guidelines is their best guess. There's no evidence that their best guess is going to be foolproof or work. And so for me, what that means is if there's still a push to do it, then we take the most conservative route feasible or possible. So my opinion on that is we become very clear about who we don't want to expose unnecessarily. So we remove the possibility of attendance in person for certain parts of the congregation, period. It may sound draconian, it may sound harsh, but we just say we're not going to allow even that mild risk to occur for a population of people in our congregation, number one. Number two, if we have a choice of content and context of the service, we would choose the minimum that mitigates risk. And this includes like having church outside versus inside, for example. Okay, we could talk more about that. But it's just making sort of the informed choices that take the most minimum risk if we're going to proceed. Okay, so that's all I'll say about that. And you guys can think about whether or not you want to have that more deliberate conversation. But let me answer a couple of questions real quick that are in the chat. The first, how does close contact impact sports activities like basketball? The NBA is about to start again. And actually, even in the NBA starting again, and they're pre-quarantine, there are people who've turned positive, right? In AAU, there are people who've actually turned positive. In freaking golf tournaments, there are people who are turning positive. So if in these non-spectator events, this is, again, so important, no spectators, even in quarantining people are becoming positive. It tells you something about how good we are at preventing this. And a lot of this has to do with human behavior. So in the PGA and the Professional Golf Association for golf, these events, people are turning positive, not because of what's happening outside during the golf tournament when they're walking from hole to hole. It's happening after they get done with their round. How people congregate at dinner, how people congregate in rooms, just because they're social animals, they're social beings. So again, it takes a lot of cooperation, a lot of really a high individual and group accountability to reduce the risk. And I'm not sure what's going to happen. I know these tournaments, some of the tournaments are canceling, some of them are going on. And it's just really a matter of time before people develop a threshold for saying it's not worth the risk. And again, the kids are going to, for the most part, do fairly well, but the kids are going to go home, or they're going to go back to the bus, or they're going to go back on the plane, and they're going to infect some other susceptible individual. And that person's going to be hospitalized, have a chronic complication, or die. Okay, Andrea, after having eye surgery, I had to use eye drops, which I can taste immediately after putting them into my eyes. This may be a common sense question, but shouldn't we protect our eyes as we do mouth and nose? Yes, we should. But again, because we're not talking about aerosol eyes, we're really talking about how we suck something in. So the negative pressure we create through inhalation, that's why nose and mouth are so important. Protecting our eyes in general, in the healthcare environment, or where you might have direct contact, yes, you should protect your eyes, right? You should, wear shields and things like that. In casual contact, it's just not enough, long enough, dense enough to cause a problem. So it's a great question. And it would mean that, again, like if you were really thinking about your question, Andrea, Andy Pandy, in a restaurant. So I'm going to be in a restaurant and I'm going to eat and sit around gabbing for 3 or 4 hours. You could argue that everyone should have on, they should have some sort of way of separating people so that even their eyes don't get it, right? Because the more prolonged exposure, the more the mucosa of the eyes are a problem. And it's why in the hospital and healthcare settings, even in the outpatient setting, people are recommending people have a shield on in addition to the surgical mask. Great question. Okay.
Dr. Harrington, somebody was mentioning to me that LAAA have that big football field out back that's a lot of open land. Do you think that's a good venue?
Absolutely. I think there are a lot of ways to skin the cat of worship. And what I'll say, and I said this, I think, on a call a couple of weeks ago, like, just go to another country. I mean, all right, now I'm going to put the United States on blast. All right.
You mean church? Go to another country?
Yeah, I'm going to talk. I'm going to talk about church and the disease control, and I'm going to compare this to another country. All right. So you guys have been watching. Well, in the beginning of all this, everyone said, "Oh my goodness, look what's going to happen to Africa. People are going to be dying by the hundreds of thousands in Africa." Okay, that's what they said. By the hundreds of thousands, people will be dying in Africa. But when we look at the data in Africa, just not occurring. Like the rates per 100,000 are a fraction of what we see in the United States. I mean, it's a fraction. And why is that? Okay. And a lot of that has to do with, even though, all Africa isn't the same, Africa represents many different countries, obviously, but no matter where you go in Africa, there are at least similarities in tendencies to outdoor. And you started outdoor and stay outdoor. So it's hard for the density to even multiply in the population when you don't have large periods of times of people indoors and congregate to each other, right? And so think about church, in some of the sub-Saharan or more sort of undeveloped aspects or countries in Africa, and people are having church without even having a tent overhead. Okay, and then you take those that have large tents and people are under a tent sitting in chairs on the ground or what have you. I can just tell you that you have thousands and thousands and hundreds of thousands and millions of people congregating in this way. And you do not have reports in Africa of people having just rampant out in villages or churches. You just don't. Okay, so again, you bring it up, Phil. Absolutely, talk about having church to kill, 3 1 stone. Get people out there. Number one, make it safe. Number two, take care of whatever sort of organization benefits of as well as personal benefits. Have reach out first. Have whatever scares you will be the way to do it. Particularly like Los Angeles, we have weather that. And if they're worried about being down on you, Big Ten, be done with it. I mean, there are a lot of ways to do this smartly and humble, maybe not.
Dr. Harrington,
And I am even at my desk. Yes.
the president has made it known that he wants schools and universities to be open by 4. So what's going to happen? And it's understandable that the youths do not get